Okay. So my name is Alia El Hazmi. I'm from Saudi Arabia, and I'm honored to have Dr. Gislan Duflé, who's from Toronto, expert in ECMO and ECHO and medical education. So we're happy to have you, and I would like to have the honor to present our first speaker, Prof. Fabio Tocconi, who's the head of Department of Intensive Care in the University Hospital in Brussels, with a lot of research activities and interest in the neurological outcome and microcirculation, and he will be talking with us today about the neuromonitoring due to extracorporeal life support run.
Thanks a lot for the introduction, again for the invitation. This session on ECLS, where I can combine my interest in the brain and in ECMO in the same lecture, so I have a few conflicts of interest for some companies producing neuromonitoring. So starting from the basis, there are several reports that tell us that in patients that will undergo ECLS, this is a study on VA ECMO, there is a proportion of them, around 15%, that will have neurological complication. And this neurological complication, of course, in some patients with cardiac arrest may even result in brain death. In most of cases, you have cerebrovascular accident like ischemic stroke or hemorrhage, and some patients will experience a seizure. This is from the ELSO registry. Of course, you might say, well, this is VA ECMO, exposure to the brain circulation to more complication, but this is true also for VV ECMO. It's a very nice review paper looking at different trials and showing that with the increasing use of VV ECMO after the 2009 H1N1 pandemics, more patients being treated, more report of neurological complication even in this patient population. I won't tell you anything about pathophysiology because it's very complex and it's a combination of the underlying diseases together with inflammation, together with complication related to the device itself and to some events like differential hypoxia that might occur when there is a kind of inconsistency between oxygenation due to the native heart with impaired lung function together with the function of the ECMO. So it's a multifactorial, but because different factors are present in our patients, that might explain why a quite substantial proportion of them may experience this complication. You may easily understand that having a brain complication in a very severely ill patient, of course, will increase the probability of poor outcome. And again, in this study from Roberto Russo on the ELSO registry, those patients who were on VA ECMO plus developing neurocomplication, 90% of them will eventually die. So, of course, it's very relevant and this is clearly a problem because, 1 of 8 patients can have this kind of complication. We should do something to potentially prevent them. Now, the point is that when you want to identify this complication and you see an ECMO patient, well, there are a lot of stuff going all over the ICU room, and sometimes you don't have access to the patient because these patients are sedated and neurological examination is limited. We are not neurologists, we're not very good into this, so we can miss some of these complications happening, and when we discover them, that's too late, there is no therapy at all. So some of the things I'm going to tell you about how to implement monitoring these patients is the summary of these guidelines from ELSO. You can read them, of course. I will try to give you my personal point of view on how to apply this at the bedside, but this is a very good document you can use if you want to consider neuromonitoring your ECMO patients. Of course, the first step is to try to have neurological examination. Again, we're not neurologists. We cannot only rely on GCS because it's very basic, but we should try to repeatedly perform neurological examination in our patients. The limitation would be that we're still using a lot of sedatives in some of the patients, and we can easily understand when the patient is heavily sedated, sometimes paralyzed, the brain becomes a black box. There is no more way to access to clinical examination. If you do nothing at all, you will not be able to identify this complication. So some of the people say, well, I use a lot of sedatives, but then I will go very frequently to do a CT scan, and then I can easily discover ischemic or hemorrhagic complication. And then, effectively, CT scan will show you most of these events. The point is that this is just a picture of the brain. If you discover the complication is already there, you cannot prevent it, so the outcome of your patients will be poor, but there is no intervention on your side to try to potentially minimize the occurrence of this event. This is where the concept of monitoring arrives. Why we do neuromonitoring is because we want to identify problems occurring to the brain before they become irreversible or extended, where potential intervention can try to spare some brain tissue with the idea, of course, not demonstrated, to improve patients' outcomes. So, of course, if you consider the perfect neuromonitoring, that will be continuous at the bedside, which will try to give you information as soon as possible as the event is occurring. Which will be our target population? The document will tell you there are some patients at risk. My idea is that if you see the risk factors associated with neurocomplication in ECMO, basically all ECMO patients will need to have some neuromonitoring, except those who are perfectly not sedated or can be easily examined. But most of our ECMO patients will deserve some neuromonitoring during the ICU stay. Can we prevent, can we predict those who are at higher risk? Just want to mention this nice recently published paper using artificial intelligence to predict the occurrence of neurological complication using different variables coming from this registry. And you see that the area under the curve is quite poor. So you cannot use patient's characteristics, underlying disease, to be sure that there will be high probability of event. So unfortunately, you need to stick with a quite wide use of neuromonitoring in these patients. Now, when you consider neuromonitoring, always consider systemic events that can trigger neurocomplications. So when you consider neuromonitoring, to me, monitoring oxygen saturation, monitoring body temperature, monitoring glucose, hemoglobin, sodium, and PCO2, monitoring blood pressure, these are all determinants that somewhat influence brain physiology and brain function. So it would be logical to ask you to put a specific neuromonitoring if you don't start from a good clinical care, looking at these easily detectable bedside variables that can potentially influence brain function. And when everything of this variable has been monitored, then you can consider additional monitoring that are specific for the brain. And because you are dealing with patients without brain injury, I cannot recommend you to go invasive. You should choose non-invasive monitoring. And this is a very nice slide summarizing what we have in the literature. You can combine ultrasound that gives you an idea on, let's say, brain perfusion with indirect measurement of brain oxygenation, the NIST technology, have an idea of brain function and excessive sedatives using, for example, EEG. And if you want to look at the brainstem, automated pupillometry is the most accurate way to assess the mesencephalic function. And the combination of those will give you a wider idea on the brain physiology in these patients. Just briefly, what we can measure. Well, if you're very good in brain ultrasound, you can also try to do some morphology assessment. It works very well in children because, of course, the thickness of the skull is thicker. But in adults, sometimes you can also try to assess brainstem and the third ventricle and look for mass expanding phenomenon. But more general, we can measure MCA, middle cerebral arterial velocities, as a surrogate of cerebral blood flow. And there are some parameters that I mentioned in the slide here that are used generally, that are implemented from traumatic brain injury as a surrogate of impaired cerebral circulation. So you can use this parameter to say, well, when there are one of these factors be identified using CBF velocity assessment, you can think these patients might have some forms of brain hypoperfusion. You can combine this with brain oxygenation, and we have this NIST technology. This is a very nice paper on ICM summarizing the existing literature of NIRS. Again, the number of studies, the number of patients is very limited, so please don't take it as the way to go. Is some suggestion, but what we basically have observed that the reduction and the persistent reduction of brain oxygenation in these patients have a quite good accuracy to predict the occurrence of neurological event, most of them cerebrovascular, when you do a CT scan. So it's possible, again, we need more studies, that the dynamics changes of brain oxygenation could be used to identify the patients with this event. The most important thing to me to remind you is that, like for extracorporeal circulation, if you manipulate some parameters like the ECMO blood flow, in particular VA ECMO, or PCO2, you will observe at the bedside changes in cerebral oxygenation. Why this is relevant? Because if you observe that your patients have a desaturation at brain level, which will respond to changes in flow, changes in CO2, this is a reversible condition. If it doesn't respond to changes in systemic hemodynamics, that might be a trigger to suggest you that these patients have an occurring cerebrovascular event. I will skip this slide because I think it's too advanced. And then the other monitoring you might use is EEG. The problem with EEG, this is a very good temporal resolution. You can monitor the entire brain, but you are dependent of an expert neurophysiologist to interpret it. So it's very difficult to have it 24 hours, 7 days per week. But you can identify seizure. In this study, looking at the very selected patients on ECMO, 20% of them will have some epileptiform activity during the EEG monitoring in the early phase of ECMO implementation. But it was more relevant in the use of EEG in the ECMO patients, not only seizure, but the fact that you can identify alteration of the background, which can suggest either reduction of the flow or excessive sedatives or the occurrence, particularly when this background is asymmetric, the occurrence of some cerebrovascular event. There could be other stuff like, on the left side, the pupillometry, on the right side, some non-invasive assessment on brain compliance. I just mentioned this to you because these are available now as non-invasive tool in a general population of brain injury patients. We have very few data in ECMO, and I think that the future research should also try to better understand the role of this monitoring system, to have more available tools to better understand brain physiology during ECMO. Now, if you want to apply these at the bedside, how you can use them? I tried to summarize on the left part, brain ultrasound, EEG, NIRS, and pupillometry. And according to what you're looking for, if you're looking for a stroke, then of course brain ultrasound, EEG, and even the NIRS will give you some indirect information, in particular reduction of blood flow or an asymmetric alteration of brain activity and electrical level of the brain oxygenation. They're not perfect, but they will give you some trigger on that patients at high risk of a cerebrovascular event. If you're looking for seizure, of course, the only way to detect seizure is using a continuous EEG monitoring with 21 electrodes that will also be very effective to detect focal epileptiform activity. If you're looking for intracranial hypertension, a combination of those could be very helpful because you not only have impaired brain perfusion, you might have brain desaturation, you might have alteration of the background of the EEG, less oxygen, less electrical activity, and you can have a brainstem impairment with the reduction of pupillary function. But you can also try to target just a brain perfusion, which is the optimal map level. You can use the Doppler, for example, or the EEG. And if you have indirect signs of reduced cortical activity or impaired brain perfusion, you might try to increase blood pressure and see what happens at the level of the monitoring. You can, of course, look at the post-cardiac arrest for prognostication. And if you are sedating your patients, don't forget too much sedatives are associated with a lot of complications, like in UR, you might use EEG in that situation. How to put this together? Can this change the patient's outcome? The answer, very easy, is not, because we can try to provide neuroprotection. We have the tools, but we don't know yet how to combine them in the best practice and how we should change our management, clinical management, based on neuromonitoring. So what the document tells you is that you can, of course, try to minimize the risk. You get coagulation, you get different factors, oxygen, as I told you, systemic variables. This is basically good clinical care you will provide to ECMO patients. And then you can also use maybe to identify patients with a high risk of complication, which will undergo much easily or more rapidly cerebral investigation with brain imaging. That could be very useful. If you identify early stroke, these patients might have a thrombectomy, so they will be very relevant to these patients. And of course, which is to me less important, you can use for prognostication. But again, before talking about prognosis, you should try to improve patients' management. This is where neuromonitoring should help you to minimize brain dysfunction. As you have seen, before concluding, I didn't talk about brain biomarkers. We have different biomarkers available in the literature that can give you different information or different component of the cells present into the brain, which, if they are elevated, might tells you there is a problem ongoing. For example, there is studies that show that if your brain biomarker is going up and you do a CT scan thereafter, high probability these patients will have a brain injury. But again, you will measure once a day. For me, this is not a real neuromonitoring because it's once a day, it's not continuous. I don't want to have a higher biomarker to see the stroke. I want to intervene before the stroke is there. This is why there is a bunch of literature of biomarkers as a prognostic factors, but to me, less relevance to use this kind of intervention to titrate our therapy. As the literature is very limited, the use of neuromonitoring is extremely heterogeneous all over the world. So we are just now with the idea of suggesting you with the guidelines maybe the best way to go. Maybe we need to implement more of this monitoring and create a registry to better understand how therapies would change what we measure, the level of neuromonitoring, and whether we can create therapeutic strategies based on neuromonitoring to minimize injury. So we're quite far to implement this. We are at the beginning of this research. So my conclusion are, you see that neurological complications are frequent during ECMO. Neuromonitoring might be helpful to better understand what's going on. We need a multimodal approach because there are different complications which might happen, and there's no one single tool that will give you all the information you need. What we basically lack today is therapeutic strategies based on neuromonitoring to better improve the clinical management of these patients. Thanks a lot.
Thank you so much. Yes, the questions will be later, since more and more are joining us, and thank you for giving us an extra 5 minutes for the time. It's my pleasure to present this next speaker, Dr. Vincent Pellegrino, coming all the way from Australia. Currently well-renowned for his ECMO work and research work, being one of the most important lead in the foundation of Alfred ECMO program from almost 20 years ago, I might say, and as associate professor in Monash University School. So it's our pleasure to hear from him about his lecture, Should ECPR be the Standard of Care in 2025?
Thank you very much, Madam Chair Lady, and thank you very much for the invitation. I'm just waiting for my slides to pop up. They're not on the screen. It's lovely to come. It's lovely to be invited and chair. Can I ask in the audience how many people work in a unit that provides ECMO? If you just raise your hand. Yeah. How many work in a unit that would do ECPR? So it's about a third of that group. Okay. So I might get into it. So my disclosures are that the most important thing is that I'm a career intensive care specialist. I've done full-time intensive care work as a specialist for over 25 years. Early in my career, I was handed the portfolio of an ECMO program at the Alfred Hospital in 2003, and I ran that as the lead till about 2022. And these days I spend my time running a state service for ECMO patients, so not just at one hospital, for an entire region to provide care through that. I'm involved with a lot of grant-funded research, but I'm not a researcher, I am a clinician, and the prospect and the perspective of this talk will be through a clinical frame. I have received financial support for honorarias for presentations in the past. So what I thought we'd talk about today is what is an ECPR program, and then to consider whether you actually need an ECPR program, whether you would want to offer an ECPR program, and can you provide such a program, and then finally, should you provide such a program? So hopefully those questions. The first thing to say is that ECPR is not just fast ECMO. It's not just ECMO with a lot of screaming, get me this, bring me that, I told you I didn't want this. That's not what ECMO is. ECPR, really, it's a very difficult specialty with borderline effectiveness unless it's operated in a very expert manner. It requires staff that are trained, retrained, accredited. They have to have all the equipment they need. And while those things are quite popular to set up, people quite enjoy setting up how to do the training, volunteers to do the work, often what I hear when I speak to other units around the world is the difficulty people have with ECPR programs is the coordination between the departments. there is absolutely no point in the ED department running an eCPR program if the ICU will not accept the patients because they're dead from ED, or the cardiologist won't do the procedures. So having coordination between the services is absolutely vital. And really for a lot of our survivors, they need more than just the ECMO to survive. They nearly always need acute and timely revascularisation, but often they need surgery and access to longer term mechanical cardiac supports. So if you don't have any of those things, it's much harder to get survivors. If you were interested in the initiation of an eCPR program, quite a lot of our resources are open access at the website ecmo.icu, and you can get there, and that's part of that program, such as inclusion. And like all clinical services, they're underpinned by two things. One is governance. So governance refers to the staff doing what they're supposed to do when they have the problem in front of them. The sporting people always talk about being predictable to each other, playing to a plan, our identity, our style. It's exactly the same in clinical medicine. We often worry about people's style being different. I think it's much more important to have a style that is observed and followed within that, and that there are rules to following up cases, learning from cases, and turning that into quality improvement. The other aspect is accountability. So you have to account for your practice. You can't exclude cases on the basis of they were going to die anyway. All cases are counted, all cases are equal, and all cases teach you. So they're very important things. Okay, so if you were to ask, do I need to have an eCPR service? The three good reasons I would start with is that that sudden cardiac death accounts for a lot of potential years of life lost. In a US study published here, you can see it's the third highest cause of potential life years lost in men, behind cancer and chronic cardiac conditions. The limits of conventional CPR are quite well known. The outcome, so on this graph, on the y-axis is a good or non-disabled neurological score at 6 months after your cardiac arrest. And you can see that even from the beginning, the survival rate from this North American series is very low, but it drops off to virtually nothing by 20 minutes. So once you don't have an immediate response from conventional or advanced life support, your outcome becomes very poor. And I wasn't planning to go through topics that are not so much de jure anymore. They were big trials in eCPR efficacy. A lot of trouble and money went into running these trials. There were 3 big ones. And there is no shortage of meta-analysis in the literature supporting the use, if you choose to believe that is important in your decision making. Those meta-analyses have been done. So you could argue that there is an overall benefit to survival. I think in terms of do you want an eCPR program, I think that's a different question to if you need one. And I said before that there were 2 axes of a good clinical program. One is governance and one is accountability. If that was really all there was to it, none of us would be doing intensive care and we would all be driving Toyotas. The world doesn't work that way. There is additional aspects to attract you to your work and get you to improve your work. And I refer to that as dynamism. Things that you want to discover, get better at, improve at, and this falls into that category very much. It's actually a really common reason people want to do it. The other reason is it's a very marketable and very powerful support. So out of hospital cardiac arrest rescued with eCPR, there aren't that many of those survivors, but when you do get those survivors, they are truly miraculous stories. They do tend to attract a lot of press. I could have shown many pictures of some of our survivors in press, but this was a feature article in the New York Times from Dennis Yiannopoulos from Minneapolis. It's also very favoured in grant applications, and in a lot of the world, eCPR is actually driven from a financial reason to do it. If you want to offer training to staff and accreditation, the good news is there are lots of tools out there. These are 3 of our devices that we've developed for our teaching program, but there are many more out there, and I'd be surprised if there were some not on view today in the industry section of the meeting. It's really common. So it's quite easy to teach people how to be able to safely insert cannulas and run ECMO. If anyone is interested in any of those products, there is access to the designer, Rizan, who's the materials engineer who's come up with all of those. The next thing is, if you're going to do all that study, you're going to invest in the equipment, you're going to build the team, you're going to structure it and govern it, you want to have something to show for your efforts at the end of it. The study I will choose to highlight was a prospective feasibility study done in Ann Arbor, Michigan, to look at this very question. So they ran this trial for 3.5 years and managed to achieve absolutely no survivors in their study group. And this is one of the things that can happen. Finding the right patient at the right time, being able to implement it and get all the steps to line up is actually quite difficult to do. And so it is important that you realise that is possible. And just to show you how much selection is there, this is a very stringently observed selection pathway in our state, in Australia, of out-of-hospital cardiac arrests that we have a go out of hospital to put them on, and a roadside service. And for 709 potential, about half of them don't turn out to be cardiac arrests. A lot of them are drug overdoses. Of the actual EMS treated cardiac arrests, only 6% are suitable or eligible for eCPR at the end of it. So it's a long time to recruit and find these patients in the community. And so that, interestingly, was exactly the same proportion in the Prague eCPR trial, that of EMS assessed and treated cardiac arrest, only 6% were suitable for randomisation. The other thing is about the trials, they don't really tell you which patients to include and which patients not to include. This is a complicated table, and I suspect you won't be interested in reading it all now, but I'll bring up the citation because we come back to it in a little while. Suffice to say that all these trials and all these programs had different inclusion and selection criteria. And while defining your inclusion criteria is one thing, getting staff to do it is another thing. So we would say the majority of people, we like to have 5 out of 5 criteria to go on. And if you have all 5 criteria, your chance of survival is almost 50% from an eCPR. But you don't get many of those patients coming in. The majority of your patients have the wrong rhythm, or they weren't witnessed, they have some other reason that makes them poorly selected. And if you put them on, you get different rates of survival. So what we've learnt over the years that we've been running this is that the inclusion criteria determine both how many survive and how many go on. And it looks a bit like this. It looks like the more you put on, the more lenient you are with your inclusion criteria, the lower your survival rate will be. And we used to just say this was true without really knowing it was true. And then what we actually did was investigate it. So this is all the patients in Australia that have had out-of-hospital eCPR. And what we did was see how many of them met different criteria. So the most stringent criteria are up, the blue dot at the top. But there was only less than 20 of those patients in the whole country over 5 years. So there's hardly any. But if you waited for those perfect set of circumstances, you got very high survival. As you went down, and in the Prague study, they included asystolic patients and PEA patients. And if you include those patients in, you get very different rates of survival. So to actually see that linearity was really interesting. So the kind of eCPR service you want is the one you will get, because if you put on patients with different criteria, you get different outcomes. So depending on what your aims are, do you want the most survivors, or do you want to have the biggest service doing the most cases, or do you want to have the highest survival rate? Because the way you go about it would be different. Just about finished. This is all the ECMO cases in Victoria in the state service that we run. This is monthly data, and what I'd like you to notice is that over the 33 months or so, 32 months that we have data for up to January this year, you can see there's very gradual, even increase in VA ECMO and VV. So they are two of the trend lines, the orange one and the blue line, and they roughly go up slightly together. We now have the most cases we get are actually eCPR cases. So they have grown to become the most popular, and most of them are in-hospital cardiac arrests of AMI patients around cath lab and in ED departments. But that's now the commonest thing. So if you open this service, the patients start to appear, particularly in the in-hospital case. And over the years we've run, the outcomes, even though we're doing more, have not gotten worse. So that was the big worry, that as we did more, we would get worse outcomes, but that hasn't been observed. So I'm just going to finish with a couple of points. So in the whole of Victoria, which has a population of, in Melbourne, had a population of 4 million, out-of-hospital cardiac arrest and eCPR survivors in 8 years, the first 8 years we ran the service, we had 14 in 8 years. So that's not very much. That'll sound there. That has risen in the last 4 years to 8 cases, 8 survivors per year. So we have seen it grow. And you might think, why go to all that trouble to do that if you're going to have so few people benefiting? In Paris, that runs the SAMU retrieval service, do a lot of out-of-hospital cardiac arrest, ECMO. They published their whole series over 550 cases. Over 7 years, only 44 survivors from their case. In the Prague study that we talked about, over the 90 months they recruited for 39 survivors. It's not big numbers, is it? In that Aroka study I measured from Ann Arbor, they had 0 survivors over 3.5 years. In the ARREST trial, which was a phase 2 trial that showed efficacy, over the 10 months they had 7. And they've extended that protocol out to more hospitals, and they have achieved sort of the highest number of survivors around there. But at the same time, in Victoria, in the state where we live, just cardiac arrest that received just conventional CPR, we had 200 VF survivors per year and 400 per year from the conventional cardiac arrest cycle. So that's an old slide, but those features are really important. In the end, it's really hard to improve the outcome from this challenging condition. If you look here on the graph over behind me, the VF survival rate in our state from our ambulance service was gradually going up year on year with little quality initiatives. It had nothing to do with the defibrillator being better. It was a whole lot of little steps, quality projects over the years. And these sort of results, and that's a very high survival. And then just with COVID, you can see that the survival rate dropped down because of the impact on staffing that COVID has, and it's been crawling back ever since. It's exactly the same with eCPR. It's not actually about the ECMO, it's about all the steps in the ECMO chain of survival, and it's a really hard thing. So the effectiveness of eCPR programs depends on many factors, and hardly anything has to do with the machine or the cannulas. You have to get that right, or there's no point. But the results have much more to do with other things than that. eCPR can't change sudden cardiac death outcomes, and we should stop pretending that they can. eCPR programs should not override conventional care because you get much more survivors from that. And if you want to do it, you want to do it for dynamism and moral reasons, I think, to do. We've made that. So in the end, we've had our meal. If you're going to make a decision about whether you need an eCPR program or you want an eCPR program, they're not equal bedfellows. Want beats need all the time. We tend to do what we want much more than what we need to do. And this was also in the Bob Dylan song from 1966, where he said, "You must know about my debutante. Your debutante just knows what you need, but I know what you want." So with that, thank you for your attention and hearing me out.
Thank you for this great presentation, which I'm sure will raise a lot of questions. We'll keep all the questions at the end. And it is my pleasure to introduce Dr. Del Sorbo, who's an associate professor of medicine at the University of Toronto, Canada. And his main academic work is focused on investigating innovative strategies to prevent lung injury, even in the context of extracorporeal life support. And he's going to talk to us about the optimal PEEP on ECLS and whether we should keep the lungs open or completely collapsed. Thank you, Dr. Del Sorbo.
Thank you, Ghislaine. Thank you, Anna, for the kind introduction. Thank you for the invitation to talk about these very challenging topics. I don't know how to start the presentation here. Okay. I don't have conflict of interest, except that I receive funding for a study related to this topic. And also I need to disclose that when it comes to decide if to keep the lung open, yeah, and so when it comes to decide if to keep the lung open or not, I have equipoise. I still don't know if we should keep the lung open or not, so I'll on ECMO, and so I'll try in the next few minutes to tell you why I have this equipoise. So a few years ago, we wrote this like expert opinion with Marco Ranieri and Tommaso Tonetti, trying to argue why recruitment and achieving recruitment in patients with ARDS may be good, because recruitment can reduce the overdistension, can make the lung more homogeneous, and so less atellect trauma, may have an effect on the cardiovascular system. However, when it comes to ECMO providing gas exchange, so improving oxygenation and CO2 removal extracorporeally, really changed completely the paradigm of how we approach mechanical ventilation in these patients. And these patients, so a few considerations. So these patients have very severe ARDS. They fail conventional treatment with proning, usually high PEEP. Their baby lung is very small, so the aerated part of the lung is very small, so they are highly susceptible to ventilator-induced lung injury. And as I said again, mechanical ventilation is not absolutely necessary here to facilitate gas exchange. So how do we use mechanical ventilation in these patients? During ECMO, optimal PEEP is completely unknown, but we know that alveolar recruitment is not required any longer to improve oxygenation, okay? However, recruitment may be functional in accelerating lung healing if the lung is recruited, transitioning from passive to spontaneous breathing may be easier, especially for the patient, and recruited lung may have a better result in terms of cardiopulmonary interaction. So what are the best conditions for the lungs to heal? So a few points here. So if we go back in the 70s, Peter Suter published this very nice physiologic paper showing how aiming for best compliance, so the optimizing recruitment in patients with ARDS leads to better cardiovascular function. Okay, so maybe we should keep the lung recruited because the heart, especially the right side of the heart, may be happier. In addition, atelectasis may be very bad. So in this very nice experimental paper in animal model, animals were exposed to 10% of FiO2 and exposure to hypoxemia, which represent maybe the same condition of an atelectatic lung, led to increase in inflammatory mediators. However, on ECMO, we perfuse the lung with oxygenated blood. Okay, we increase SVO2, so I'm not sure that there is very much hypoxemic condition, even in atelectatic lung. And if we look at this very nice physiology paper by Bellani and Antonio Pesenti that did CT and PET scan in patients with ARDS, actually what they show that atelectatic area are not so inflamed. most of the inflammation is in the areas where there is a risk of overdistension. Moreover, if we have a patient on the floor with lobar pneumonia that has maybe nasoprongs, we don't try to recruit that lung. We know that giving antibiotic, the lung will recover and return to normal function. So I'm not sure we should really pay much effort in recruiting our patient. And last, there's a beautiful example of natural extracorporeal circulation, okay, in the fetal circulation, where the lungs is completely collapsed for several weeks and returns normal in one breath after birth. So I'm very much puzzled. So should we use high PEEP to facilitate in patient on ECMO to facilitate lung recovery, preventing atelectasis, and have better cardiovascular function, or maybe should we let the lung to collapse? Okay, atelectrauma may not be a very important mechanism of ventilator-induced lung injury. We can use even zero tidal volume because CO2 is clear by extracorporeal means. So should you recruit or not recruit following an editorial by Foti and Pesenti in the past? So, but let's go at the bedside. So what the literature says, how much PEEP is used in clinical practice. So in the two large randomized trial on ECMO, the CESAR trial, the OLIA trial, in CESAR trial they use 10 of PEEP, okay, which is considered relatively low. In the OLIA trial they use at least 10 of PEEP and they titrate the PEEP up to achieve 24 of plateau pressure. And here is the graph of the PEEP. So not very much change or difference compared to the ventilated control group. Matthew Smith in observational trial in 2015, though, showed that patient with on ECMO with a higher PEEP in the first 3 days of ECMO cannulation had a better outcome. So if the PEEP was higher, their outcome was better, their survival was better. Unfortunately, in 2019, he repeated a large multi-center observational trial and didn't find any association between PEEP and survival in this patient. So should we instead titrate PEEP according to recruitability? So as I said, these lungs are the baby lung is very small, so is it even recruitable because they fail a high PEEP? So Camporota did this very nice trial measuring recruitability in patient with ECMO, and found similar result of patient on ECMO that we found in patient not on ECMO, so the recruitability covers a wide span, okay? So should we titrate PEEP according to recruitability? That's what the French group tried to do here using electrical impedance tomography, EIT, and found that the optimal PEEP, which is the compromise between overinflation and atelectasis, is different according to the patient, of course, because each patient is differently recruitable. However, I argue that they still use some tidal volume. If we decrease the tidal volume to zero, this point of compromise may change drastically. Nice data come from this Asian randomized control trial. It's a single center randomized control trial. The intervention group aims target the decision of PEEP according to transpulmonary pressure, okay, measuring it with esophageal manometry. And the control group is PEEP between 10 and 15. They show that targeting or titrating PEEP according to esophageal manometry, the absolute value of esophageal pressure, the PEEP is higher, and patients are weaned from ECMO earlier. Okay, there is maybe a trend in mortality, but it's a small trial, not powered for mortality. However, in the nice crossover physiologic trial, in 20 patients by the German group here, 20 patients were exposed to either 10 of PEEP, called the PEEP ELSO, as per guidelines recommendation, PEEP titrated according to best compliance with the decremental PEEP trial, or PEEP titrated according to esophageal manometry. And they found actually that the PEEP ELSO, so 10 of PEEP, is the best PEEP that is resulting less mechanical power, better cardiac output. So I'm still puzzled. Should we use 10 of PEEP or should we use higher PEEP? So we're studying this topic, and we found that this patient on ECMO very severe, with very severe RDS, may have also airway closure, what we call the phenomenon of very high airway opening pressure. This is a case we published in the Blue Journal. You can see doing a low inflation PV curve, we found this notch, which is corresponding, if you can see that, to 20, almost 19.9, almost 20 centimeters of water. So if you do the calculation, there is abrupt increase in pressure with very, very low tidal volume. So if you calculate the compliance of that part of the PV curve, is about is about 2 of compliance. It's about the compliance of the ventilatory circuit. So we claim that before that point, the airway is completely closed. So if we ventilate this patient, for example, with PEEP of 10 and driving pressure of 10, we won't generate any tidal volume because we are below the airway opening completely, okay? So this maybe needs to be taken in consideration. And so we're doing a close study in Toronto, and Dr. Duflay knows very well because she's doing all these maneuver and immediately after cannulation of our patient. Okay, our hypothesis is that completely airway closure is highly prevalent in patients on VV ECMO, and if we ventilate this patient with PEEP below airway opening pressure, their course will be more complicated and probably the outcome is worst. So again, should we keep the PEEP high or low? Should we keep the lung recruited or not? So I don't know. That's a final answer, and therefore we decide to design a trial called the pressure trial, where we is a pilot trial for feasibility to understand if we are really able to maintain the lung recruited at least for 7 days with PEEP either set at 20 and the maximum plateau pressure of 25, or PEEP titrated according to airway opening pressure compared to our conventional PEEP strategy in our center, which is the 10 centimeters of water of PEEP as recommended by ELSO. So stay tuned. Maybe in a couple of years we'll know the final answer. Thank you very much.
Thank you very much, Lorenzo. Our next speaker is Dr. Kiran Shekhar, who's a senior intensivist and director of research at the Prince Charles Hospital in Brisbane, Australia. And his main interest is to study the variability of patients in critical care, especially in ECLS. And his topic today is to discuss whether pronin should be the standard of care for patients on ECLS.
Thank you.
He's coming for your slides.
That's all right. All right. As probably the last speaker for the day, I'm not going to keep you guys for too long. While we wait for the slides, how many of you practice proning your patients on VV ECMO in your center? All right. Okay, I'm going to turn your world upside down with my talk. Let's see. This one, brother. Yeah. All right. Here we go. This is probably one of the most controversial topics at the moment in the field of venous ECMO. I do not have any conflicts relevant to this talk today. Look, if you ask me, should prone position be standard of care or routine? A simple answer is no. Of course, that will raise some eyebrows, and this is, as I said, a very controversial area. But also we need to be very objective about what we know about ARDS in general and all the other therapies we have developed over time before we make this conclusion. So in the next 15 minutes, I'll try and convince you why the honest answer probably is we don't know. I think we need to go back a little bit and look at the key trials in ARDS. I think it's where it all started. These are the 4 key trials most of us who practice ICU would be well aware of. Starting from this particular trial, which sort of revolutionized our practice in the early 2000s. Clearly, in early 2000s, even though there was observational data, most of us were not as aware of lung protective ventilation. And this study changed the field in a big way, and where we saw that ventilation with low tidal volumes and regulating the pressure led to better outcomes. And that to date remains a very seminal study in our field. And there were several secondary analyses that followed, including that nice paper from Amato, which introduced the concept of driving pressures. So we were not only restricting tidal volumes, we now, even though it's a secondary analysis, we are more mindful of driving pressures. And around the same time, people thought maybe even in those patients who don't have that stiff lungs, maybe restricting tidal volumes even in those patients may be beneficial. So in essence, people started wondering, if low tidal volume is good, how low can it be? Whether reducing the tidal volumes much further, will that be useful? Of course, without the use of extracorporeal support, you can only reduce the tidal volume to a certain extent. Around the same time, there was observational data that was coming through that prone positioning may be helpful and may improve outcomes. And that led to the PROSEVA trial, which in ARDS, which looked at benefits of prone positioning in ARDS patients. And before we get to the PROSEVA trial, the question is, why do we prone at all? And the hypothesis, and which is well described in electric impedance tomography studies and other animal models also, is that when we ventilate people with ARDS, of course there are dependent and non-dependent portions. There is cyclical opening and closing of the dependent lung regions, whereas the non-dependent ones, there may be over-distension. So that means there is ongoing ventilator-induced lung injury. The idea is that by proning these people, we can distribute the ventilation, redistribute the ventilation, intensity of ventilation in a more homogeneous way and overcome some of the respiratory system compliance issues. But that is a well-proven concept in even computed tomography studies, and a lot of work has been done. So there is a strong biologic plausibility for proning these patients. And all that mechanistic data and observational data led to this study, which looked at prone positioning in patients with moderate ARDS. And we did see a very significant survival benefit, and that's now become standard of care. So low tidal volume ventilations, reducing ventilatory pressures, and prone positioning, this is what we know were standard of care. And what was also interesting, which is relevant to what happened later as the ARDS management evolved, is in the PROSEVA study, even though there were patients where there was improvement in oxygenation, that need not necessarily lead to better outcome in itself. So what we tend to believe now is the benefits of prone positioning doesn't come from improving oxygenation. It comes from protecting the lungs, minimizing ventilator-induced lung injury. So since the ARDS net low volume ventilation trial, we figured out, okay, prone positioning can reduce ventilator-induced lung injury, and equally, it goes without saying, extracorporeal respiratory support, be it carbon dioxide removal extracorporeally or ECMO, can reduce ventilator-induced lung injury to a much larger extent, because you don't have to ventilate the patient technically. So once again, we probably got a bit carried away, and we're still figuring out how to ventilate the patients on ECMO, but there is a line of thought that why ventilate patients at all? Let's do complete lung rest. And there are proponents of apneic ventilation or not ventilating, and there are others who are a lot more reasonable and try and do lung protective ventilation. The reality is we don't know the answer, but we know at least now that there is enough evidence that VV ECMO works, even though earlier was a trial that wasn't conventionally positive from a statistical significance point of view, 11% difference in mortality between the groups. In most other circumstances would have seen as a positive trial. But VV ECMO in ARDS is now standard of care. And since earlier we had further questions, just like we asked whether we can lower the tidal volumes further, after earlier now we are asking, can we lower the driving pressures, tidal volumes, and mechanical power much lower than what earlier trial did? And for those who remember the earlier trial, earlier tried to ventilate people with tidal volumes to maintain a plateau pressure less than 24 and driving pressure less than 14. And that was their trial protocol. But it's possible to further reduce the intensity of ventilation. That's one way to see if there are more benefits. And around the same time, many centers started positioning their patients on VV ECMO prone. So once again, it came from the same desire to further minimize ventilator-induced lung injury. So other way to look at it is if low tidal volume is good and if prone positioning is good, if you put them both together, is it going to be even better? And that's just probably could be human nature or whether it's hypothesis generating. Once again, there was a lot of observational data that led to a randomized controlled trial I'm going to talk about soon. But these are some of the hypotheses of why do we do or why do we combine prone position and VV ECMO. Obviously, even during VV ECMO, because we reduce the intensity of ventilation, as discussed previously, there is atelectasis, significant atelectasis of the lung. That can further worsen hypoxemia, actually, depending on how much PEEP the patient is on. And some would also argue that letting the lungs just collapse and consolidate may even delay the weaning from ECMO. So once again, these are hypotheses. And if we prone these patients, maybe we can minimize the de-recruitment. So that's why people try to do it. It also may reduce ventilator-induced lung injury. So all of this combined, there may be some benefit to the patient. And indeed, such benefit was observed in few observational studies. And that led to this nice study from Mathieu and his colleagues in France. Essentially, it was a study that compared conventional supine VV ECMO versus prone positioning, early prone positioning, and they recruited around 170 patients. This happened during the pandemic, so it, in a way, it helped the trial because they could recruit patients quickly. That was also a problem. I'll tell you why. The primary outcome was successful weaning from ECMO 60 days, which was reasonable. And it was a well-conducted study. Both groups were well-balanced. They received similar adjunctive interventions and good supportive care. They had a very clear, standardized weaning protocol. As I said, the baseline characteristics between group was very well-balanced. Because the study happened during the pandemic, of course, almost all of the patients had COVID-19 related ARDS. And what was also interesting is the excellent uptake of prone positioning prior to ECMO. And as you can see, that once again was balanced between the group, but that may also have some implications. But there was no difference in primary outcome. ECMO weaning rates were similar in both groups. This is the study, and when we look at some interesting subgroups, because in those groups which had compliance greater than 20 centimeter or less than 20, there was no significant benefit. Once again, in patients who had a higher BMI versus lower BMI, there wasn't much difference. So on all counts, this study failed to show any benefit whatsoever. Also, some other secondary outcomes as listed there. None of them were any different between the groups. Also, interestingly, there were not many complications, which is also very reassuring, because if someone really says, I want to do it at any cost, please go ahead and do. But if you've got a well-trained team and if you can, it can be done safely. I think in some studies like this, even absence of harm is equally an important finding, even though there was no benefit. So what do we make of it? Of course, routine prone positioning, which is quite labor intensive and risky at times to the patient, need not be performed, at least based on this data. And there was no obvious harm, which is reassuring. The question then is, we're already doing ultra lung protective ventilation on VV ECMO. Is there much more to be gained by turning them upside down, especially if you're doing good, diligent lung protective ventilation? Maybe the observational studies, like they always do, had some bias based on indication and treatment allocation. And generalizing a study that recruited 94% of COVID-19 patients to all other forms of ARDS may also be a stretch. So just based on this study, it's tricky to say don't prone at all, but routine proning probably is not indicated. Also in prone ECMO study, they recruited all comers. They didn't have any enrichment strategy. So whereas in observational studies, typically they recruited patients who were hypoxemic on VV ECMO, which sometimes I've done too in my practice, or those who were struggling to wean from ECMO, or the CT scan had showed significant consolidation which was not resolving. And we have done that few times in such patients with some temporary benefit of oxygenation. Whether that translates into survival, we don't know. But clearly it looks like maybe we need to enrich the trial population and redo the trial. But ECMO trials are very, very hard to do. Earlier trial, which took 10 years, if you start enriching VV ECMO trials, probably we'll have to do intergenerational trials and some of us will be dead. And we need to have a steering committee that has, multiple generations. So the question is, why didn't we see the benefit? If it was so good, why didn't we see benefit? This is where I think maybe we are wrong from first principles. Maybe prone positioning, especially of people who are not ventilated, is not that great. ProSiver showed benefit because people were getting ventilated, so you could distribute ventilation. So what is there to distribute if there is no ventilation? So just turning them upside down maybe of not great benefit. So clearly, especially if the ventilation is only dead space ventilation with few mules, we may not be achieving much. And that was demonstrated in the prone ECMO study, because in both groups, as the intensity of ventilation went down, there was progressive decline in respiratory system compliance, which indicated just lungs getting stiff and consolidated. So maybe there's not much to be gained. If there is no ventilation, proning people may not be beneficial. That's the point I was trying to make earlier. And also, even if you hypothesize proning will improve secretion clearance, maybe that's one mechanism where you can get enough gas flow into them. But that was also not observed in the prone ECMO study, because there was not even an improvement in oxygenation. So the only question to be asked then is, maybe not in the early stages, but when the patient starts to breathe on their own, or when we increase the intensity of ventilation at later stages of ECMO, maybe is there a utility of prone positioning then? But once again, that's a separate question, and that needs a separate trial as well, because prone ECMO was a study that looked at early prone positioning. So then the question is, late prone positioning, why not? And is that what you want to do? I want my patient to be walking around rather than lying upside down later in the stages of ECMO. So these are some of the thoughts, but then the question then is, if these are the patients who were prone before ECMO, they failed prone positioning, then you put them on ECMO, and then if you prone them again, is the patient going forward or backward? Don't know. And once again, the future trials will have to answer this. But other way of looking at it is, instead of making them bed bound and sedated, paralyzed, prone position, can we use VV ECMO as a bridge to early rehab, getting them going? That's another way of looking at it. I don't know how many of us still have equipoise for prone positioning of VV ECMO, but I'm starting to worry about the physiologic rationale in itself if there is no ventilation at all whatsoever in these patients. Or maybe if we decide to prone them, maybe we'll have to continue some level of ventilation rather than completely resting the lung. So this is, I think, Luciano's name came up earlier, I think, to remember the great man. This was one of the very nice editorials of the many he's written. This is one of the nice one he had written about how physiology-based practices sometimes, however good they look like, can lead very conflicting results. Some of us who work, most of us work in ICU, but we can relate to several of these trials where, for example, many, many decades ago, there was a concept of supranormal oxygen delivery, and we all went through a phase when I was just getting into ICU. We were targeting everything supranormal, and then finally that was debunked by clinical trials. Sometimes everything can be wrong. We start with the wrong premise and end up with the wrong conclusion. That I think the goal-directed therapy was one of such a trial where it was quite an interesting study in itself. Sometimes we have a very good biological rationale and also the evidence agrees with it. And when that happens, it's fantastic because everyone's happy. And that was the low tidal ventilation study, which I mentioned earlier. And sometimes it can be strange, you have very strong physiologic rationale and you keep looking for evidence and you never find it, but it works and we continue to use it. That could be the PEEP in ARDS. So essentially, physiology helps us to design studies and gives us a rationale to design a study and provides theories. But whatever the trial result is, if you misinterpret it based on the physiological rationale, or if the evidence is misinterpreted, then it can be a dangerous thing. So future directions, I think we can't say we should never prone anyone, but I think routine proning shouldn't be done. There may be select groups of patients where we can try, and that needs to be figured out. Maybe only in a clinical trial setting. Maybe we need to look more at using ECMO as a means to get these patients mobilized early and also look at more diaphragm protective ventilation. Hopefully the future looks like this. With that, I finish my talk. Thank you.
Thank you very much for staying late. The amount of audience explains how much they are interested. I would like to invite the speakers to the podium, please. It's a very interesting session where you could link the first two talks together with neurological monitoring and outcome with the ECPR, and you could connect also Kiran's and Lorenzo's talk together about keeping the lung open and is proning the way to do it or else. So we'd be happy to receive any questions. We'll start with Sarah. Go ahead.
So Lorenzo, you talked about the optimal beep during ECMO. So my question going to be, what about extubating patient during ECMO and losing all mechanical ventilator? Because we had a few cases where we succeeded with extubating them, but they present less than maybe 1% of all the cases we do. What do you think is the barrier toward extubating patient ECMO, despite we are in ECMO and we're providing them with proper oxygenation and ventilation, but despite that, some patients, we even need to paralyze them because their work of breathing is so high. Is there any way we can overcome that?
Yeah, so it's a very good question. Thanks, Sarah. So, yeah, there is a nice case series published in JAMA from the University of Chicago using Protect Duo. They were able to extubate early all the patients cannulated on VV ECMO for ARDS. I don't think anyone was able to replicate that study. Definitely there are some patients that are, let's say they have less inspiratory effort, and it's easier to win them, win mechanical ventilation before winning ECMO, and so extubating them. Let's be mindful that patient can have self-induced lung injury, especially when the lung is very, very inflamed and severely injured, like the ones that require VV ECMO. There are nice experimental studies on spontaneous breathing in animal models of ARDS Takeshi Yoshida published this very nice paper showing that mild ARDS, so spontaneous breathing, mild ARDS leads to a better histological and outcome. But in severe ARDS, spontaneous breathing may actually make the lung injury much worse. So I don't know if we should extubate or not. So far, we have only case report, and there is, of course, a publication bias there as well.
Okay. Any more questions?
Yeah, I have a question.
Please.
Can I ask you a question to Fabio? So thank you for the presentation. It was very nice. So we, as Sarah, as the last question alluded to, we try to wake up and wean sedation very early in inpatient, both on VA and VV ECMO. Is still multimodal neuromonitoring required, with the technique that you mentioned, despite them being maybe awake and not as sedated? Yeah. And then can those techniques predict?
We use
outcomes
Altera for more than one case based on the criteria that you have mentioned. It was successful.
Someone responding,
and then we have one patient post-congenital heart surgery, and he improved, but then he deteriorated further.
Is the other room, so it was not related to it.
Okay. So are the multimodal monitoring, can that predict event that the physical exam or interaction with the patient cannot?
Well, I would say this is complex because even having a patient who is calm enough, being awake and keeping all this stuff on his head is quite complicated. You will have a lot of artifacts because of patient's movement. So interpretation will become very complicated. The answer is yes and no, in the sense that even in patients who are clinically evaluable, you might have clinical examination which become impaired. You still don't know which is the mechanism. It might be, renal failure. It might be a specific brain process. Then the neuromonitoring might help. So I would say yes on one side. But on the other side, I think that we need to learn from these patients where neuromonitoring is the only way to monitor, because clinical examination is not available, before translating this to the patients who are awake, because the risk is that if you monitor something, there's something wrong, because someone told you this is abnormal, you will provide intervention. And as you know, when you treat in the ICU without any evidence this is effective, you might provide harm. So I think we are quite far to understand how to do therapies, and I would like to have some data on, let's say, the ones that we want to monitor because there is no clinical examination, before moving to those who are available, in which at that moment I would use more clinical examination and monitoring on demand.
Nice.
Any questions? One question I have, which is, in the event of ECPR, is there anything in the first 6 to 8 hours from a neuro monitoring point of view that could help us predict the neurological outcome? Or something that we could study and see within the first 24 hours that could help us predict? Because as it was illustrated, that the outcome is not the best. For example, in my center, we do the ECPR in the ER and inside the hospital, mainly for acute MIs, and in the referring hospital around us, because we have hubs for cath lab that serves certain geographic areas where sometimes they arrest in the peripheral hospital or in the way, so we send an ECMO team to them rather than going homes and so forth. So our outcome is different. But the question always comes, especially asking for support, financial support, admin support, other departmental support, which is one of the huge challenges for ECPR maintenance of the program, because everybody's excited in the beginning, but when they review the numbers, that's when they have cold feet. Anything that could help us prognosticate the neurological status after the ECPR?
You want to answer first?
Yeah, I can say a few things. Most ECPR patients that are cannulated during cardiac arrest are so unwell in the first 12 hours that you can't really get a lot of information. It's just seeing if they can survive to the morning, usually, is the normal thing. They require a lot of blood transfusion. We've just studied this. And so they have a lot of blood transfusion, they have a lot of product transfusion, they have a lot of scanning. They're moving around the hospital, they're really sick. It is possible to cone and become dead in that 6 hours, which is a clear sign that, yep. But usually it's just a clinical effort to get the patient stable enough that you can do a neurological assessment. And the worst thing you can do in an ECPR program, and this was unfortunately very prevalent in the Inception trial, was not provide the amount of supportive care the patient requires. The average time they were on ECMO in the trial was 1 day. Now, in that trial, in our patients, if you survive ECPR, you have 5 days of ECMO, maybe 6, and you're in the ICU for 3 weeks or 2 weeks. It's a very severe illness to get over. There's frequently bowel ischemia, lots of other things, which makes neuro assessment so difficult. And we take the perspective that we cross our fingers and our toes that the brain will be okay. But it's very hard to get a clear picture for many days. You have to be committed at every level to wait and see it through. And I would be very sceptical, even if an expert told me that they could predict it early. I'm not buying it. I will wait until I'm convinced in 2 weeks or 3 weeks.
Yeah, I can only add what he said, which is what we basically do. We try to provide full support to this patient because there is this self-fulfilling prophecy stuff. We lose some patients because of systemic events. What will they do? They will die of, bleeding, whatever. Those who survive, the first night, everything's okay. Then we do a lot of monitoring. So I can tell you which patients has more than 90% probability of dying, but we prefer to still stick to the program. And again, in Belgium, the advantage is that we have a program of mastic tree organ donation. So there are some patients who will not recover the brain, but because of full support, they can recover the kidneys and the liver. They will become organ donors. I mean, if the family, of course, agrees. We have a quite good proportion of patients who go through this. And this is at the level of a community. I know it's a very cynical and ethical, debatable. At least in Belgium, consider us something that provides information for, something for the society. So we try to treat these patients the best we can the first 72 hours of those who survive. We accumulate all this information to neurological evaluation, and we can stop finally sedatives. We do our assessment as we do for cardiac arrest patients, and then we decide at that moment. We still are quite conservative.
Because what we do in our center, we believe that the CT images do not correlate with the patient. Many times you see a very normal CT and the outcome is horrible, where you have diffuse punctate hemorrhages and patient still wakes up and follows command. We've seen both. So we try to tell the team, forget exactly what Prof. said. Don't think of that just now, because then the people would start day 2 and day 3 saying we should continue or not, probably cutting short their chances.
What you don't have to miss is the 20% who will become brain deaf, because of course you don't want to treat the patients with brain deaf. That happens, especially if your selection criteria are a little bit wider. Yes. You might have up to 20% of brain deaf patients, and that would be, of course, different. Yes. So you can identify these patients with the combination of EEG, Doppler, and pupil assessment, but this is a minority of patients.
Any questions from the audience, please?
Thank you very much. I have actually 2 questions. The first one is regarding the airway closure. When do we measure it? And if we're going to measure it, how frequent we will measure it later on? And my second question is, there's a lot of studies regarding early mobilization and the reduced duration of mechanical ventilation. But my question is it the time to question or to compare supine position, prone position, and early mobilization? Thank you.
Yeah, so very good question. So airway closure. It's very easy to measure airway closure, area opening pressure. Just need to do the patient needs to be deeply sedated without generating any spontaneous inspiratory effort, so either deeply sedated or paralyzed. And you drop the flow, inspiratory flow, or the bios flow to 5 liters per minute or less, and you do a sustained inflation. Each ventilator can do it in different ways. And so it's just a way of doing a PV curve. And then you either plot your PV curve or you analyze the pressure over time curve. And if there is this notch that I showed you, that suggests is the demonstration of an airway opening pressure that is not a PEEP, okay, but is higher than PEEP. In our protocol, we do once a day, as long as the patient is deeply sedated or paralyzed. Okay, so it's relatively easy. We're trying to get as much information from many centers about the prevalence to understand if it's more prevalent in a patient on ECMO than in patient on not supported with ECMO. And I can say 2 words about the prone position and early mobilization. Yeah, so I was questioning the statement that the prone positioning in the trial of Matthew Smith and Lancome did not cause any harm, because we don't know. The patient, to be prone, they need to be deeply sedated, okay? Otherwise, they may not tolerate. And as many centers tend, as I mentioned before, to wake up the patient earlier, maybe to facilitate early mobilization. That may be,
Great, Loud, your questions, both of them great questions. Yeah, look, I think there's a more nuanced answer to this, whether it's proning, supine. I think once we get patients to that level of sickness and on multiple supports to maintain gas exchange, and so it's a very heterogeneous population. I don't think there's any one-size-fits-all approach for these patients. And also, it's not realistic to do clinical trials, because of the numbers, and it's very tricky to do those trials. But if you look at it, most of us have done VV ECMO, and the patient goes through all of those stages. There may be a stage where it's just bomb them out, sedate, paralyze, and protect the lungs. Then, if need be at that stage, you may choose to prone them in highly selected patients. Then they go through a phase of waking up, and sometimes physiology just limits you of what you can and can't do. You just have to, at that point, survive. So I don't think we should get too carried away, like we see videos of patients walking around on ECMO. We all have those videos, but not everyone can do that. So we just have to do at that point in time, optimizing the physiologic support and not overdoing it. I think one of the mistakes we do is we over-support. We probably have unrealistic oxygenation targets probably on VV ECMO, which is what is leading to, once again, high levels of support. I think that's what, just like we had low tidal volume ventilation and permissive hypercapnia as a consequence of that, if we start doing lower blood flow ECMO, permissive hypoxemia will have to be a consequence we'll have to tolerate. Otherwise, you can't do mobilization and high flow ECMO at the same time. So something has to give. There's a physiologic limit. So you can only mobilize your patient at a certain point in time, no matter how hard you try.
We can add the Carol Oxon, they just finished the recruitment in a pilot study looking at early mobilization versus standard of care in patient on ECMO. So stay tuned. I don't know the overall result of this pilot trial, but I'm curious. Yeah. So it's a very hot topic. Yeah. Thanks for the question.
Definitely hot topic, and I agree with Kiran in his presentation. Probably the prone ECMO didn't show much because there wasn't the high PEEP you're describing on the high tidal volume to redistribute once you shift. My question is, if we combine Lorenzo's vision of very high PEEP of 20 plus minus a 15 or 14 driving pressure, would you think, and I don't know, that's a pure guessing probably, would you think that would have been a positive study?
Look, it's hard to say. I think for me, if these patients were great responders to prone positioning, they probably wouldn't have needed ECMO in the first place. Maybe there's something to start with, because you already probably have failed the intervention. You're re-challenging them with a similar intervention with less ventilation.
Yes.
So I don't know what it means. To answer your question, I think there is this misunderstanding. Atelectrauma is a real thing on ECMO. You just drop the intensity of ventilation and the lung turns white. And we then go through that phase and make it hard for ourselves probably. Once again, this is opinion. I know I don't have evidence to back any of these arguments. But that atelectrauma, there's an assumption that just PEEP is enough to overcome that. I have an issue with that. I think some degree of tidal ventilation is probably also necessary. Not just, it's like you can have apnea with high PEEP. So you are the expert, so which is better then?
Yeah, so I was questioning why 14 of driving pressure? If we use 20 of driving pressure, of PEEP, we use 5 of driving pressure. So we decrease that dramatically. Otherwise, I'm convinced that we would induce ventilator-induced lung injury. So if I may add, so the key question, as you pointed out in your nice presentation, is how do we prevent VILI? So we know VILI may still occur in patients on VV ECMO. Okay, so how do we prevent it? Is really proning the best strategy or not? And the problem is the control, because there's so many options out there, increasing the PEEP, doing near apneic ventilation. So the problem is really the control.
And just also a practical question for the expert, as all the trials near DS showing some effect are those basically minimizing VILI. Why a patient putting on ECMO in the early phase? Should I try to open anything, It might be a reasons for, doing late when you want to maybe recruit the lung before winning the ECMO, but as I'm putting the patients at rest, putting an extracorporeal support, what should I try in the early phase, at least, of ECMO implementation? As you said, these patients has been treated with very aggressive ventilation. Should I even try to put an IPEEP? Of course, if there is a tolerance, if there is enough oxygen saturation to allow the patients to be on ECMO. I think these are all the questions where, the randomized trial with the one specific setting of starting at that moment with everyone treated the same way, it's a little bit, tricky at the level of understanding physiology. We would like to individualize the choice and having multiple possibility to adapt if VILI is the main issue. So you want to adapt to those who the VILI is the higher, you want to quantify the bedside. Again, is a comment from, not expert in the ventilation, from the bedside when we always discuss PEEP, not PEEP, driving pressure using an ECMO. And I said, we don't care about oxygenation. All the trial of low tidal volume, basically the oxygenation was even worse in the low tidal. So oxygen is not an issue, provided that you put an ECMO. We could wait. It's a possibility to test in the future, timing,
Yeah, it's a very good point. So two answers this. One, if we let the lung to completely collapse, to reopen, so we know the reopening pressure is much higher than the pressure that is required to close. So, to try to open it in a later phase when we may want to wean the patient is more difficult if the lung is not open. But then we decide to do the pilot trial because we don't even know if applying our strategy, we're even able to keep the lung open. Because it may result that in 7 days, there's no difference in lung opening between the different strategies, as suggested maybe by the crossover physiologic study of the German groups. That's why we decided to run on 45 patients in this trial. So it's a very good point. Thanks.
Thank you so much. Any more questions? We're using the time offered by the speakers finishing before their allocated time to interact more and discuss more. So we thank them for the very interesting discussion. If there is no other questions, any questions?
I have a question to Lorenzo.
Yes, please.
Because we're now looking at permutations and combinations, would you think if we had the oscillator but did a bit more gently?
Sorry, if we?
High frequency oscillation, even though we wrote it off, but what we are saying essentially is you want good recruitment, very little driving pressure. So do you think we wrote off oscillation prematurely, or why not prone, oscillate, and then ECMO?
Yeah, no. I think if we need to turn something, rather than turning the patient, I would just turn the knob of the PEEP or rather than the patient. And I think HFO, I think, is done, unfortunately done. Also, it's another nice example where the physiologic rationale is fantastic. There are, animal data showing its benefit and observational data that were not confirmed in 2 large randomized trials. So
it may be because they forgot about the right ventricle, though.
Yeah.
Just saying.
Exactly.
Yeah.
I was just trying to make it a bit silly.
Yeah, no. And unfortunately, because it was, developed in Toronto, and so, and Toronto gave his final blessing.
Yeah. Any more questions? Okay, Gislan, anything? Thank you very much. We really appreciate you. Thank you so much. And it's very rich discussion. Thank you.